I'm really pleased to introduce Jonathan Rogers, our speaker today, who is a psychiatrist from London, currently doing a PhD fellowship at UCL. It's a really special pleasure to introduce Jonathan because he's a graduate from Cambridge. He's one of the first students I supervised for an SSC project on cortisol and sleep many years ago. And he graduated 6 years ago and has done pretty well since. Did an academic clinical fellowship at the Maudsley and is now doing a Wellcome funded PhD at the UCL looking at catatonia. And then fairly early on in his PhD, he noticed that there was this coronavirus causing a few problems and thought it made sense to look into coronaviruses a bit better. Managed to get a paper in the Lancet Psychiatry, which isn't bad for diversion. I heard Jonathan speak a couple of months ago on the Maudsley series, I think it was, and it's quite nice to see his name there. I assumed it was the same one. He had a great talk on it, but I understand that our knowledge has increased massively in the last 2 months. So I'm probably going to hear quite a different talk now. Okay, Jonathan, over to you.
Thank you so much. It's delightful to be back with you. Even though it's virtually, it feels a little bit like coming home to Cambridge, which is probably my favourite place in the world. So thank you very much for the introduction, Paul. I was doing this PhD in catatonia and suddenly had to stop everything because of the inconvenience of COVID. So I decided to do a systematic review related to COVID. As you might be aware, COVID has a fairly long lag between onset of symptoms, which tends to be the fever, the upper respiratory symptoms, the myalgia, and the systemic symptoms like fatigue. And then it tends to be after 7 days or so that hospital admission happens for those who are unfortunate enough to be unwell. And the ARDS develops a couple of days later, intensive care unit admission around day 10. But what's really interesting in this awful pandemic is the role of psychiatry and whether COVID-19 affects mental health. So what I'm going to try to do today is give a little bit of an introduction to coronaviruses and talk about why this might be an issue that we'd want to investigate, and discuss how we went about the literature search we did, and then talk about the meat of the presentation, which is talking first about the acute implications of COVID on mental health, and then thinking about, and this will be a little bit more speculative based on prior outbreaks of coronaviruses, on what might happen further down the line, and we'll think about some of the implications of this. I'm aware that there's a wealth of clinical and research experience in the virtual room with us, so I'd very much be interested to hear your thoughts and questions later on. Coronaviruses are single-stranded RNA viruses that are heavily enveloped. They've been around for a long time and affect both humans and animals. So this is far from the first coronavirus outbreak we've had. There are 7 strands that are known to affect humans. 4 of them are common, and they're catchily named things like HCoV229E, HCoV OC43, etc. And these 4 common coronaviruses account for about 15% of the common cold that have been endemic for hundreds of years. What we've seen in the last 20 years is 3 outbreaks of coronaviruses that have really stuck above those peaks. The first was in 2002 in Hong Kong, which is the severe acute respiratory syndrome, or SARS, which many of you will remember. A word on the terminology. So SARS is the disease, and the SARS-CoV, the SARS coronavirus, is the virus that causes it. It was thought to have come from bats and killed, infected several thousand people in Hong Kong. Then we had, in 2012, 10 years later, the Middle East respiratory syndrome, or MERS, caused by the MERS coronavirus. And this was a little bit different. First, it was much worse than SARS in terms of its case fatality ratio. So SARS killed about 1 in 10. MERS killed about 30% of patients. The second thing that's been quite different about MERS is that it's never been fully eradicated, and there continue to be small outbreaks of MERS, mostly in the Middle East. And that's probably because although MERS, like SARS, probably came from bats, it seems to be transmitted via camels rather than person to person. And then finally, as we're all aware, on the 30th of December 2019, China alerted the WHO to this novel coronavirus, COVID-19. And this is called, the disease is COVID-19. The virus is called SARS-CoV-2 and bears a lot of similarities to SARS-CoV. Why are we interested in coronaviruses in psychiatry? Well, there hasn't been a huge amount of interest in them, but there's been one group led by Bob Wilkinson, which has published a couple of studies on coronaviruses and mental health. These are very different coronaviruses. These are the common forms, which cause the common cold. And this is looking at antibodies to these viruses, so people who have been infected at some point. And they've conducted 2 case control studies. One was using a large group of patients with mood disorders, comparing them to healthy controls. And they found that patients who had been infected with the HCoV NL63 subtype were more likely to, patients with the mood disorders were more likely to have been infected with this strain of coronavirus. And then they found a similar thing with psychotic disorders. But this is just from one group and it hasn't been replicated. So why, in the current climate of COVID-19, should we be interested in, as psychiatrists, in the implications for our patients? There's been lots said about the implications of lockdown and social isolation. I'm primarily going to focus on the effects of COVID-19 for people who are actually infected, rather than the wider social implications. As a worst case scenario, encephalitis lethargica was a severe neuropsychiatric complication, possibly of the Spanish flu pandemic in 1918. It was characterized by Parkinsonism, catatonia, psychosis, and lasted for decades. It was made famous in Oliver Sacks's book Awakenings, and subsequently in the film with Robert De Niro. Its link to Spanish flu, however, is controversial because the first cases of encephalitis lethargica were reported in 1917, and the Spanish flu didn't happen until 1918. And there has been a failure to actually find any of the virus in the brains of patients with encephalitis lethargica. Nonetheless, I think it's plausible to think that given that this started out of the blue and then went away within a period of a few years, it does seem likely that there was some infective trigger. That's a worst case scenario. What's perhaps less controversial and less speculative is the psychological impact of COVID-19. So any severe illness can cause an acute stress reaction. For a couple of months during the pandemic, I went back to work in liaison psychiatry as a registrar in King's College Hospital. And we saw a number of presentations seemingly triggered by the psychological effects of COVID-19. So there were patients who objectively were getting better, but were terrified because they were convinced that they were going to die because of the media coverage they'd seen. There were patients who were really struggling because they couldn't speak to friends and family. Visitors weren't allowed to come in. And if they weren't tech savvy, they were struggling to communicate with their family members. There was also the issue of patients becoming confused and feeling, well, patients feeling short of breath and in a very stressed state, wishing to remove something from their mouth because that might have been stopping them from breathing. Unfortunately, the something in their mouth was actually the oxygen mask. So we got involved in these kinds of cases on the wards. Another facet of COVID-19 which makes it a little bit unique is the difficulties that patients are experiencing communicating with staff. I went to see patients who I'd met before but didn't recognize me because I looked like everyone else. When patients were communicating with me, it was through several layers of plastic, which doesn't help establish a rapport. And of course, longer term, there are the employment and financial difficulties that patients with COVID-19 may be facing. And I'm sure we could together make a list 10 times this long. I think it's also important to be aware of the iatrogenic impact on patients with COVID. Being intubated and sedated, being on ITU, is a pretty awful experience for many patients. And it's not even as it would be normally because ITUs are running short on propofol, and so having to use different agents, often midazolam, which has different psychiatric effects, as we're aware. And there seems to be some prolonged confusion in these patients, possibly related to that. And corticosteroids are being used in patients with COVID-19, and we'll come back to that. The million-dollar question, though, is whether the SARS-CoV-2 virus actually affects the CNS. And quite early in the pandemic, in April, Ling Mao and colleagues published this study in JAMA Neurology, Neurologic Manifestations of Hospitalized Patients with Coronavirus Disease 2019 in Wuhan, China. And they did a retrospective review of just over 200 patients' notes in Wuhan. And the headline figure was that 36% had neurologic manifestations, which made quite a buzz around the world. However, when you really dig down as to what these manifestations are, they are mostly things like dizziness, headache, impaired consciousness, which are really commonly seen in any systemic disease and don't necessarily suggest a primary neurological involvement. The altered sense of smell of 5% is much lower than what we've seen in prospective studies that have actually asked patients about anosmia. They did find some interesting associations with these so-called neurological symptoms, though. Patients who had neurological symptoms tended to be older, had more comorbidity, and actually tended to have fewer of the typical COVID symptoms. So is this neurological involvement of COVID-19 biologically plausible? Well, SARS-CoV-2, like SARS-CoV, enters cells via the ACE2 receptor. And it's now established that these are present on multiple cells in the CNS, so not only the neurons, but also microglia, astrocytes, and oligodendrocytes, the myelinating cells. And there are several plausible routes of entry. So it might transfer between neurons in the synapse. There's been lots of speculation about entry via the olfactory nerve and whether this anosmia indicates actual neurotropic invasion of SARS-CoV-2, or whether it's just whether this is just nasal congestion, infection of the vascular endothelium, or whether this is related to leukocyte migration across the blood-brain barrier. There was a recent paper in JAMA Neurology, though, which had this rather revealing statement after having discussed all this. Although there are reports of neurological complications in patients with COVID-19, it is unclear if SARS-CoV-2 is neurotropic in humans. So I think that the jury is still out. So we went about looking at this by doing a systematic review. We searched the standard databases, but given that the field was and still is changing so rapidly, we also searched preprint databases. We first ran the search and got a number of hits on the preprint databases. And then just before we submitted it, I think we ran it again 2 weeks later, and the number of articles had doubled. And we included patients with suspected or confirmed coronaviruses. coronavirus infection, plus any psychiatric or neuropsychiatric complication. And we define psychiatric and neuropsychiatric quite broadly to include delirium all the way through to mental health, quality of life measures, symptoms and diagnoses. We found a lot of articles, about 2,500 of the databases, and then 50 through other sources. When we went through them, we found that about 70 of them actually had the kind of information we wanted. There were a lot in Chinese, unfortunately, that we didn't have because we wanted to get this out quickly, and we didn't have the time to translate them, so they weren't included. And 7 made it into a meta-analysis. I'm going to step back from the systematic review now and just talk about some of the things we find, but also some of the data that's come out since we published this paper, because it's already looking a little dated. So in terms of the findings with SARS and MERS, acutely, I used to skim over the qualitative data, but I found that giving talks on this area tends to actually be the area I'm asked most about. Acutely, a lot of patients experience loneliness, boredom, frustration. They were very concerned about having infected in family members or being about to infect family members. And by and large, they were very grateful for the support they'd received from health services. In terms of systematic assessments of symptoms, there are a couple of papers that did this. It's worth stating that you need a word of caution when interpreting these figures, because both studies were retrospective and they were both self-report. So some of the definitions of these terms might not be the definitions that you and I as psychiatrists might give them. Nonetheless, they're quite interesting. So lots of the things you'd expect: insomnia, anxiety, depressed mood, pressured speech, even some euphoria and aggression, which is quite intriguing. When you come back down to some of the less common things, a number of patients reporting auditory hallucinations and persecutory ideas, which I don't think didn't make much sense to us until we looked at some of the other symptoms that have been reported, which I intentionally left out from the previous table. And here you see that almost 40% of patients reported impaired concentration or attention. 34 had impaired memory. There was confusion in 28%. Patients were emotionally labile. All of these, to me, are sounding like a delirium picture here. 1 in 5 had altered consciousness. So the headline here seems to be that there was probably delirium in a significant proportion of these patients with SARS. In terms of psychiatric diagnoses, these were much, much rarer acutely. So although a lot of patients reported low mood, actually the cases of depression were uncommon and more or less what you'd expect in a random sample of hospitalized patients who haven't been prospectively screened. What's very interesting, though, was 16 cases of psychotic disorders. And there was one study that explored this in some depth. I reported 15 of these cases. It was just under 1% of all the cases of SARS in one hospital. And they compared the 15 cases with psychosis to 30 age and sex matched SARS patients without psychosis. 13 of the 15 were diagnosed by a psychiatrist with steroid-induced mania or psychosis. And steroids were used very commonly to treat SARS. What was interesting, though, was that the vast majority of patients who developed psychosis and those who didn't were prescribed steroids. And although the psychosis was associated with a higher cumulative corticosteroid dose, it wasn't actually that much higher. And they also found that a family history of psychiatric disorder seemed to predict the development of psychosis, but the numbers were very small. The recovery trial is using dexamethasone in the UK, and has shown it has shown some promise. So I think if we get a lot more cases of COVID coming to hospital in a second wave, I think it's likely that we'll see more steroid-induced psychosis. What about delirium in COVID-19 though? So we've talked about SARS and MERS. Moving forward to the COVID-19 literature. A couple of studies have systematically assessed neuropsychiatric symptoms. There was one in ITU patients after extubation, and of course there are lots of confounds here because of the sedation and the ITU stay, but the majority were agitated, and of those who were agitated, most were confused. Interestingly, they followed up most of these patients until discharge, and they found that a significant minority, about 10%, still had a dysexecutive syndrome once they were discharged from hospital, characterized by inattention and disorientation. There was another study of 82 patients who subsequently died in Wuhan. So again, these are going to be the most severely unwell patients, and 17 out of 82 of these had altered consciousness. There are 4 other studies that reported confusion but haven't assessed it systematically, and they found rates between 2 and 22%. This is the literature we had when we submitted our review, and then just before it went to press, a preprint for a very large study came out, and these are data from the UK arm of the International Severe Acute Respiratory and Emerging Infection Consortium, with 16,000 hospitalized patients. Again, it was retrospective, but it used routine health records and found confusion in about 20% of these patients. Now, assuming that by confusion we're talking about delirium, it looks like among hospitalized patients with COVID-19, delirium is as common as it was in SARS and MERS. What about symptoms of depression and anxiety? There have been a few studies in the acute phase. There are lots of limitations with these studies, as you can imagine. So I find it very difficult to assess depression and anxiety in the presence of acute medical illness. Lots of the biological symptoms are difficult to untangle. There was a study in Wuhan of 144 patients, and this found that about a third of them had symptoms of anxiety and slightly lower symptoms of depression. Interestingly, a study in Zhejiang compared 87 patients with non-COVID pneumonia to a COVID cohort and found that the COVID patients did have higher scores on anxiety and depression scales, whether that's due to the illness or whether that's a biological consequence of the illness or whether that's a psychological consequence of being told you have COVID, of course, isn't clear. Some of you will have heard about the CoroNerve study, which is a British study led by the Association of British Neurologists and supported by the Royal College of Psychiatrists. They published in JAMA Psychiatry a couple of weeks ago their first 153 cases. This study relied on clinicians reporting cases of suspected or confirmed coronaviruses that were thought to be associated with neurological or psychiatric manifestations. The bar for reporting is quite low. You don't need to be certain that there's a causal link. You just need to suspect it. And the results are really quite interesting. The headline is that there's a lot of stroke, but the next largest group is so-called altered mental status, which I think is neurologist speak for anything from delirium to depression. Some of these were encephalopathy, a few encephalitis, but there were a lot of psychiatric diagnoses, including 10 new onset psychoses, 6 so-called neurocognitive syndromes, and a few affective disorders. An interesting story about this paper actually is that it was initially submitted to JAMA Neurology, but because there's actually so much psychiatry that they came across in their results, it was eventually published in JAMA Psychiatry. So in terms of the key points, in acute COVID-19, The stress of having a severe infection is enormous. Delirium is likely very common, but specific neuropsychiatric syndromes are probably rare. I'm going to move on now to talk about the post-illness impact. And here we don't have any COVID-19 data, so I'll be relying entirely on data from SARS and MERS. In terms of symptoms, again, this is a retrospective self-report measures, but still a significant number of patients saying that their concentration and memory isn't as good as it used to be, being a bit emotionally labile, and about 1 in 5 experiencing persistent fatigue. In terms of disorders, we did a meta-analysis for anxiety disorders, depression, and post-traumatic stress disorder. And the follow-up ranged between 3 months and about 3 years. And in terms of the anxiety disorders, we found it was about 15% prevalence. Depression, it was almost exactly the same, 15%. What really stood out to us, though, was that the PTSD rates were much higher at 32%. And if you look at the follow-up periods here, actually there isn't any consistent difference in the rates of PTSD between the very early studies and the much later ones. So this could be something that we're dealing with for several years now. In terms of rating scales, the hospital anxiety and depression scale has been used in 3 studies, and the average score is below the clinical cutoff, but it's still reasonably high as the population average. There have also been several measures of quality of life in patients with coronavirus infections. The short form health survey ranges from 0 to 100, and there are various domains. Important for us, there's the social function, the role limitation due to emotional problems, and also mental health. In terms of the social function, patients with SARS had 25 points less on average than healthy controls. Emotional problems, they had 15 points less. And in terms of mental health, they had 10 points less. I think this is quite revealing, actually, and it's a word of caution to us in suggesting that coronaviruses may have a specific effect on mental health. Actually, the effects on global well-being, on social function, seem to be bigger than anything specific on mental health. In terms of employment, 3/4 of patients had returned to work at a follow-up time on average of about 3 years later, but that still leaves 1/4 who hadn't. So what are the implications of all this work? Well, I think the first is that the research so far has a lot of limitations. Even some of the ongoing COVID-19 studies don't have a control group. And we didn't find any studies with information on premorbid mental health conditions. So it's really hard to know if patients had depression or anxiety because they were affected with SARS, or actually whether they had this prior to the illness. I think the reporting bias is going to be substantial, particularly with studies like CoroNerve, which definitely have a place, but where they rely on clinicians finding interesting patients and adding them to data repositories. And I think as a related point, some of the terminology is problematic too. So they found in CoroNerve that there's been that neurologists tend to talk about encephalopathy and psychiatrists tend to talk about delirium. And so they might be reported in very different ways. Also, pretty much all the data on SARS and MERS and a lot of what's coming out of COVID-19 is about the minority of patients who are hospitalized. And that's for good reasons, in that we can confirm the diagnosis. We know if there's anything else going on with them. And it's a good time to recruit patients. but most patients with COVID-19 aren't being hospitalized, and probably a majority of patients with COVID-19 aren't getting a definitive diagnosis. So it's very hard to do studies on what psychiatric complications they might be experiencing. In terms of the comparability of COVID-19 compared to SARS and MERS, the mortality does vary substantially, as I mentioned earlier. The ITU admission rates among patients who are hospitalized are actually much more similar. So for the SARS, it was 13%, and for COVID-19, it's 18%. MERS was worse in pretty much every respect. But in terms of patients who are admitted to hospital, there might not be that much difference in terms of what we see between SARS and COVID-19. I think the implications of delirium being present at high rates could be very significant. Delirium is associated with a prolonged hospital stay of about 7 days extra on average. It's associated with a protracted recovery and higher mortality in the 3 months following an episode of delirium. So we need to be viewing this as a red flag for unwell patients. And I think there's been lots of discussion about ceilings of care and who should be escalated for ITU. And I think bearing in mind that 1 in 5 of our COVID patients in hospital might have delirium should make us very careful in approaching mental capacity, in making sure we consider mental capacity when we're having those serious discussions with patients. In terms of the follow-up, there are these 4 big areas that came out of the review from previous coronavirus outbreaks: depression, anxiety, PTSD, and persistent fatigue. The British Thoracic Society guidelines recommend asking about psychosocial status at follow-up. And I understand anecdotally that there's been quite a lot of concern when respiratory physicians have started screening for mental illness, because they're finding a lot and not being sure how to refer these patients on. Some people are suggesting bespoke psychiatric clinics. I think the problem with that is that what we're seeing with COVID-19 is not some very specific post-COVID syndrome. We're seeing the whole mix of things that psychiatrists are used to seeing. We're seeing exacerbations of pre-existing disorders, and we're seeing affective disorders, we're seeing anxiety disorders. And actually, a clinic with very specific referral and acceptance criteria might screen out a huge amount of the morbidity. If you're interested in this topic and you want more information, there are a number of sources I can recommend. So there's a live blog on the Journal of Neurology, Neurosurgery and Psychiatry website, which is being updated with all the COVID-19 psychiatry and neurology studies as a live systematic review. If you do see any patients with psychiatric consequences of coronavirus infections, do report them on the CoroNerve platform, which is supported by the Royal College. It doesn't preclude you from writing a case report yourself. The initial reporting is very brief and easy to do. Unfortunately, they do then send you a follow-up email and want quite a lot of information. Interestingly, the Secretary of State for Health, Matt Hancock, has issued a memorandum to NHS Digital, not only allowing them to share NHS information for the purposes of COVID-19 surveillance, but mandating that they do so. So some of the information governance requirements around normal research in the NHS have been liberalised a little bit, which has made studies like CoroNerve possible, where you don't actually need patient consent in order to report. Hopefully other studies will be able to take advantage of this too. We've also got a multidisciplinary team meeting, which happens weekly at the Queen Square National Hospital for Neurology and Neurosurgery, and is led by Dr. Michael Zandi, who was in Cambridge not that long ago. And we have a neuroradiology, infectious diseases, and neuropsychiatry present there. So if you have any particularly unusual patients, that's one route of referral. Our paper is open access, so feel free to have a look at it. So in summary, delirium is really common in patients hospitalized for COVID-19. Depression, anxiety, and particularly PTSD are likely to be significant in the follow-up period. Specific neuropsychiatric syndromes are probably going to be rare, but they probably do exist. And I think we need to be aware of the big stroke risk that we're seeing. But the good news is, and perhaps one of the most important ones for our patients and for the public, is that most patients will not have a mental illness after COVID-19. Thank you.
Great. Thank you very much, Jonathan. Okay. So thank you very much for telling us more about it. And yes, things have moved on since I last heard you talk. And I guess it's a reassuring picture that actually the majority won't get mental illness, although clearly physically we know there's really bad long-term complications for lots of these patients who end up in hospital.